You're listening to Medscape's In Discussion series on endometrial cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ursula Matulonis, Chief of the Division of Gynecologic Oncology at the Dana-Farber Cancer Institute and Professor of Medicine at Harvard Medical School. She is the first recipient of the Brock Wilson Family Chair at the Dana-Farber Cancer Institute. She co-leads the Gynecologic Cancer Program within the Dana-Farber Harvard Cancer Center, the Ovarian Cancer Specialized Program in Research Excellence, SPORE grant from the National Cancer Institute within the Dana-Farber Harvard Cancer Center, and an NCI P01 Program Project grant that is focused on targeting replication stress in high-grade endometrial cancers. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Ursula Matulonis. Welcome to Season 2 of the Medscape In Discussion Endometrial Cancer podcast series. Today, I am honored to have as my guest Dr. Gini Fleming, who is a professor of medicine at the University of Chicago and is the medical director of gynecologic oncology at the University of Chicago. Dr. Fleming is an expert in advanced breast and gynecologic cancers, and Dr. Fleming has authored and co-authored more than 200 articles for a variety of medical journals, in addition to a number of textbook chapters, and she is a pioneer in the field of gynecologic oncology. She also serves as an associate editor for the Journal of Clinical Oncology. Dr. Fleming, welcome to the Medscape In Discussion Endometrial Cancer podcast.
Thank you so much. I'm delighted to have been invited. As you know, talking about endometrial cancer is one of my favorite things.
As I mentioned, you are truly a pioneer in the field, really doing so much seminal research. So we're going to go back down memory lane a little bit, but also we're going to cover a number of different topics, including getting Dr. Fleming's thoughts on the state of uterine cancer in the United States, the role of immunotherapy in endometrial cancer, what her priorities are for research in this field, and talk about what she sees as new and promising therapies for endometrial cancer. My first question to you is that, as you know, the 2025 cancer statistics were just published in CA, a journal for clinicians, this month, and once again points out the emergent situation with endometrial cancer. Over 69,000 new cases are expected to be diagnosed in the United States this year, and the paper points out that the only cancer for which survival has decreased over the past 4 decades is uterine cancer. Uterine cancer is one of the few cancers that has increasing mortality and also has one of the largest black-white mortality disparities. It's really amazing that year to year, the statistics for this cancer continue to worsen. So, Gini, what do you think about these statistics, and why do you think the stats are getting worse for this cancer year to year?
That is a $6 million question. I think all of us had noticed for many years that every time we give the annual fellows talk on endometrial cancer, we had to update the slides for the numbers, which wasn't true for all the other cancer types because they were changing so fast. But what hit me like a lightning bolt was an article by Dr. Clark in 2022, where she published an overview showing that when adjusted for hysterectomy rates, and of course, hysterectomy rates in the United States have been decreasing, and it's not possible to get endometrial cancer if you don't have a uterus. So that could produce some artifactual rise in endometrial cancer rates. But when you adjust for hysterectomy rates, the mortality from the more common endometrial cancer over the past years has been stable. But the mortality from non-endometrioid cancers, such as carcinosarcoma and uterine serous carcinoma, as well as their incidence, has been steadily increasing year by year. Both uterine serous carcinoma and carcinosarcoma are much more common in Black women than in white women. For example, if they get endometrial cancer, Black women have about a 4-fold chance of getting uterine serous carcinoma compared to white women. This has also resulted in a rising increase in the disparities of outcomes from this disease, because outcomes for women with uterine serous carcinoma and carcinosarcoma are so much worse than those for the more common low-grade disease. So review articles, which raises my hackles constantly, are always citing that it's a rise in obesity that is the underlying cause of rising mortality rates from endometrial cancer. But this makes no sense to me. While all endometrial cancer is clearly somewhat obesity-related, low-grade endometrioid tumors are more related to obesity, one very good analysis noted that if you just look at per 2 kilogram per meter increase in body mass index, you have an odds ratio of 1.2 for low-grade endometrial cancer, but only 1.1 for the aggressive subtypes. So if this were the cause, then we ought to be seeing a concomitant or greater rise in the low-grade endometrial cancers. This can't be the main cause for the rise in rates of death from endometrial cancer. However, so far as I can find, any actual information on what contributes to the development of high-grade endometrial cancer is lacking. I mentioned, and which many people mention, that there is an increase of endometrial cancer in younger women, but this is generally low-grade endometrial cancer. It is likely obesity-related, but I don't think it's what's driving these mortality figures that are so alarming.
It really is remarkable, the number of endometrial serous cancer cases, carcinosarcoma. Certainly when I started my career, these were really rare entities. And now, in our tumor boards, they're quite a common diagnosis. And as you correctly mentioned, just more aggressive and less treatment sensitive. And I know we're going to talk more about treatments in a little bit. I just want to move to a hotter topic in endometrial cancer, and that's really around immunotherapy. And you gave the invited discussant presentation at SGO in 2024 for the updated NRG GY018 and the Ruby overall survival data. And of course, you did a knock it out of the park job and a really wonderful job. There was an overall survival trend towards benefit for the use of immunotherapy added to carboplatin paclitaxel in both trials for patients with mismatch repair proficient advanced endometrial cancer. But as you said, it was not as, quote, dramatic as seen in the mismatch repair deficient advanced tumors, but that immune checkpoint therapy should be considered to be added to chemotherapy in front line. I think for mismatch repair deficient, I think everyone agrees it's the right thing to do, unless there's a huge contraindication. But for mismatch repair proficient, we still grapple with this. So can you talk about predictive biomarkers to help you decide the use of checkpoint inhibitors in mismatch repair proficient cancers? And then can you talk about the clinical situations of patients who have a mismatch repair proficient cancer where you would really consider recommending adding a checkpoint inhibitor to chemotherapy? Or do you discuss it with all of your patients?
I am not perfectly consistent on this topic. I think that you may well remember after my giving that talk at SGO that your colleague came up to me after the presentation and very passionately opined that I was not correct, and that I said that I thought that the major reason that patients with mismatch repair proficient disease had some benefit, or that some patients had a benefit from immunotherapy, was probably not the subgroup with high tumor mutational burden, despite mismatch repair proficient disease. And he said that he believed this was wrong. So I did a little bit more homework after that and reviewed publication of the Garnet trial. The older people in the audience will remember the Garnet trial as a test of single agent dostarlimab in women with advanced or metastatic endometrial cancer. So on this trial, they accrued a fair number, 161 patients who had mismatch repair proficient disease and had a response rate of 15%. So they actually published an attempt to tease out what might have accounted for responses in this 15% of patients. They looked at patients with a high tumor mutational burden. 11 of these 161 with mismatch repair proficient disease had a high tumor mutational burden. And of those, 5 of 11 had a major response. So that is, in fact, fairly convincing. Now, this excluded the patients with polymutant disease, although one of them was POL-D mutant. There were 5 patients separately with a polymutation, and 2 of them responded. So I think that if you try to add up the numbers, as I did on the sort of back of an envelope, doesn't account for all the responses that are seen, but certainly patients who have a high tumor mutational burden, even if they have mismatch repair proficient disease and do not have a polymutation, should be among those treated with upfront immune checkpoint inhibitor therapy, as, of course, patients with a polymutation. And I think that all patients should have next generation testing at the time of development of metastatic disease, if it wasn't done before, in order to help with this determination. Now, what I see being done in the community largely is testing for combined positive score, that is for PD-L1 expression. And they, in the Garnet trial, also looked at this. They found that if the combined positive score was greater than 1, which is the cutoff, say, in cervical cancer, it has not been shown to be prognostic in other endometrial cancer trials. But anyway, if the combined prognostic score was greater than 1, that 22% of patients had a response. If it was lower than 1, it was 7%. So maybe there's something there, and a patient with low tumor mutational burden and a low combined positive score, I would really probably discourage from getting treated, although I might discuss it with them. Whereas those who have a high tumor mutational burden or a polymutation should definitely get immune checkpoint inhibitor therapy. Now, for the in-between cases, I'm really not consistent. Sometimes I use it in a non-scientific way if I think I don't have much time to get to a second-line therapy and I want to get every chance of benefit. That is to say, the patient is not going to make it to second-line lenvatinib pembrolizumab. I discuss it with most patients since it is FDA approved. I just don't encourage it in everybody. Or if the patient very much wants it, then I'm certainly willing to prescribe it if there's no contraindications. But I have no qualms whatsoever about not giving it in most of these patients, particularly if they're eligible for a different trial, for example, GY26 testing adjuvant anti-HER2 therapy.
There's so many factors that go into our decision making. And I think, time and studies and data sets will help us eventually make better decisions about who to use checkpoint inhibitors on, who not to. But I totally agree with your thoughts. I just did a podcast with Panos Konstantinopoulos a few weeks ago within this series about hormonal therapies for advanced estrogen receptor positive endometrial cancer. And not infrequently, we are faced with the patient who has an advanced estrogen receptor positive cancer, lower grade, maybe grade 1, mismatch repair proficient, and let's say tumor mutational burden low. And we have to make that decision between chemotherapy with or without immune checkpoint inhibitor. So that's one decision. And then sometimes, especially if they've got metastatic disease, thinking about hormonal therapy. So obviously, if someone's stage 3 without evidence of metastases, then consider chemotherapy. But if they've got lung metastases or nodal metastases, asymptomatic, how do we think about these patients and the fact that, we've talked about this already, and you mentioned that checkpoint inhibitor combined with chemotherapy is now FDA approved for advanced endometrial cancer, regardless of mismatch repair status. It makes us all feel obligated that we have to discuss checkpoint inhibitors, even in mismatch repair proficient cancer. So my question to you is really, what factors for you go into the decision to use a checkpoint inhibitor combined with chemotherapy for mismatch repair proficient advanced ER positive endometrial cancer versus starting with the hormonal therapy? If you do decide to eventually use a hormonal therapy before starting chemotherapy, how do you decide which hormonal therapy to use?
I have no qualms whatsoever about starting with hormone therapy, perhaps because I also treat breast cancer, and that is the standard pathway in breast cancer, perhaps because when I started treating endometrial cancer, endocrine therapy was the first-line standard. Chemotherapy plus immune checkpoint inhibitor is not curative. For patients who are not symptomatic from their disease and who I believe may do well for a while on endocrine therapy, I will generally start with endocrine therapy. I'm fairly old style about how I decide who to start at endocrine therapy. That is to say, if the tumor is strongly ER/PR positive, I consider that a better candidate than someone who is, say, weakly ER positive, PR negative tumor. Patients who don't have any symptoms, patients with grade 1 or 2 endometrioid histology who have not progressed rapidly after adjuvant therapy. These are the general candidates. I think that prior endocrine therapy does not decrease the response to subsequent chemotherapy. Indeed, many of our current chemotherapy trials allowed prior endocrine therapy. I'm not so sure that the converse is true, in that I suspect that chemotherapy will decrease the response to endocrine therapy, perhaps causing the tumors to mutate more. I'm not sure. In any case, I use this fairly frequently. If there's no trial available, and I look for a trial to put these patients on, I tend to use alternating progestin and estrogen. I don't have strong feelings about which regimen, but I do not use much single-agent aromatase inhibitor, just because in the single-agent trials, single-agent aromatase inhibitors has had the lowest response rates of any endocrine therapy. That being said, these are small trials that are conducted across many years, and I don't know that the data are very convincing one way or the other. As you know, there's now 3 trials published showing reasonable response rates to endocrine therapy plus a CDK4/6 inhibitor. And because, again, I treat a lot of breast cancer, I use this combination quite a lot. If I can get insurance to cover it, I will use that combination, but that's not always easy. I do occasionally use everolimus letrozole, but my patients tend to have a high incidence of diabetes, making that sometimes a tricky regimen to use.
I agree on the everolimus letrozole. I worry about its lung toxicity, and it's not easy, especially obviously with the hyperglycemia. So I want to shift gears a little bit to kind of hear about your thoughts about future directions. And there was a recently published report just a few weeks ago in December of 2024 from the National Academies of Sciences, Engineering, and Medicine that talked about women's health funding and the NIH here in the United States. The report really bemoaned the lack of funding for women's health and definitely called for an increased funding for endometrial cancer. And this cancer now receives about $15 million per year, which is far less than breast, ovarian cancer, as well as cervical cancer even. So I just wanted kind of to understand what you view as research priorities for endometrial cancer moving forward.
It's an exciting time for endometrial cancer, and there's lots and lots of interesting directions. But as we sort of discussed already, I think unless we address and research the causes of high-grade uterine cancers, such as carcinosarcoma and serous carcinomas, and the treatment of these cancers, I don't think we're going to address either the rise in deaths from this disease or the increasing racial disparities from this disease. So I would have to say those would be my national research priorities. Not, however, that there aren't many other interesting directions.
Yeah, I agree with you on that one. Tell us what you're most excited about regarding new or emerging treatments.
Well, I think for all of us, the Destiny trial results, when they were reported, made one of the happiest days in a long time for women with 3+ levels of HER2 in their tumor by immunohistochemistry. Trastuzumab deruxtecan, the drug studied in the Destiny trial, produced an 85% response rate with prolonged time to progression. And in those with 2+, it was a 47% response rate. The drug is now FDA approved for any tumor type with 3+ expression by immunohistochemistry. And the Destiny trial is ongoing to accrue more data for women with lower levels of HER2 expression. As you know, it's approved for patients with levels of 1+ or 2+ in breast cancer. And I've seen dramatic results in patients with 1+ levels in that disease. I would like to eventually see this moved adjuvantly for patients with high-risk disease that's 3+ positive. Despite the risk of pneumonitis, I think that it will increase the cure rates. We need, of course, to await the results of the adjuvant trials of naked anti-HER2 antibodies in endometrial cancer. But having personally run studies of naked antibodies in endometrial cancer with 0 response rate in multiple patients with 3+ IHC, I'm not so confident that those are going to be positive trials. So that's one area that, again, it's not the majority of patients, but it is a reasonable percentage of patients with serous carcinoma, which again, I think is a priority for us. There's other antibody drug conjugates, potentially TROP2-directed agents that are showing promise in endometrial cancer as well. And I'm looking forward to larger trials with these agents. There is also, I think, still the unanswered question about adjuvant bevacizumab or frontline bevacizumab in endometrial cancer. It's an old study, but in GOG 86P, patients, again, as you said, a blast from the past, were randomized to get bevacizumab or temsirolimus added to frontline chemotherapy. And the patients who had P53 mutated disease had a hazard ratio of 0.61 benefit for the use of bevacizumab, whereas there was no benefit in patients who had P53 wild type tumors. I believe that NRG has an upcoming trial that will be comparing immune checkpoint inhibitor therapy to bevacizumab added to chemotherapy frontline in patients with P53 mutant disease, and I think that should be a very worthwhile trial. There is still the ongoing trial of prexasertib as maintenance after frontline chemotherapy for patients with endometrial cancer, that again in the P53 wild type group. There's many issues in the treatment of patients who have mismatch repair deficiency. Not all of them are cured with immunotherapy. And if they progress on their frontline checkpoint inhibitor therapy, what's the next best step? Should they just go on to lenvatinib, pembrolizumab? Should they get more aggressive immunotherapy such as ipilimumab, nivolumab, CTLA-4 inhibitor combination or other combination? What should the frontline therapy for mismatch repair deficient disease be? There's still ongoing trials testing single agent immunotherapy versus chemotherapy, and those results may inform our practice. And there's an ongoing trial in the NRG GY25 that is ipilimumab, nivolumab versus single agent nivolumab that I think is well worth accruing to. So there are a lot of promising directions. I think after many years of having no or one approved drug for endometrial cancer, things are finally moving in the right direction.
Yeah, lots of exciting avenues, but also, as you pointed out, lots of work to do and lots of trials to run. So I'm going to finish up by asking you if you'd like to talk about any endometrial cancer research that you and your team at the University of Chicago are working on right now.
The one thing I'd like to comment on and working on would be as in a very preliminary area of working on, but the microbiome is sort of a wide open, new Wild West area to me. But there are fascinating findings with the microbiome. Numerous researchers are here at the University of Chicago, including one microbiome/immunotherapy scientist who has mouse models where he's identified which bacteria promote anti-tumor responses to immune checkpoint inhibitor therapy in these mice. And by changing the bacteria in their gut, he can make the tumors resistant or sensitive. And he's working on the mechanisms of this. As you know, there have been very intriguing reports of transplant of fecal specimens from responding patients to improve the efficacy of anti-PD-1 therapy in patients with melanoma. And I think that relevant models in endometrial cancer would be very exciting. And this is, again, an area that I think is in its infancy. But immunotherapy, unlike antibody drug conjugate therapy or chemotherapy, can be curative. And I think that improving immunotherapy results is one way that we can definitely decrease mortality of advanced disease.
Well, that sounds really interesting, especially the microbiome really sounds really cool. So, Ginny, I want to thank you so much for being here today. It's been a real pleasure and an honor. And today we've talked to Dr. Fleming about the state of uterine cancer in the United States, the role of immunotherapy in endometrial cancer, specifically mismatch repair proficient cancers, her priorities for research in this area, and her thoughts on new and promising therapies for endometrial cancer. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on endometrial cancer. This is Dr. Ursula Matulonis for the Medscape In Discussion Endometrial Cancer podcast.
Thanks for listening to Medscape's In Discussion Endometrial Cancer podcast series with our host, Dr. Ursula Matulonis. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on endometrial cancer.